My name is Phil Perazio, and I'm a urologic oncologist, a surgeon. Like many of you, I absolutely love what I do, and I would not choose another profession. But I have struggled with professional identity, practice efficiency, and wellness over the years. Operate with Zen is a podcast designed to explore a mindful approach to surgery and to being a surgeon. By discussing these struggles and mindful solutions, I hope together we can create a community of strong and healthy surgeons. Enjoy. Welcome to this episode of Operate with Zen. Today, I have the great pleasure of being joined by Dr. Carter Lebares. Dr. Lebares, introduce yourself to the audience, please.
Hi, everybody. I'm Carter Lebares. I'm a acute care and GI surgeon at UCSF, and I'm director for the Center of Mindfulness and Surgery. And I'm really honored to be here.
Yeah, so we crossed paths because I read a bunch of your papers and your work and was super excited to talk to you about mindfulness in surgery and some of the real applications that we've seen and some of the data. So before we get into the data and the really exciting stuff there, give us a little bit of the origin story. So where did mindfulness start in your surgical practice, and where did this all develop from?
Well, I got interested in mindfulness even before I applied to medical school. I was actually just looking for some way to de-stress and found myself at the San Francisco Zen Center. I don't think I even looked them up online. I mean, this was quite a while ago. I think I maybe saw a flyer or something. That's how old school it was. But they allowed people to come and sit at 6 a.m. in sort of the outer hallways around the actual kind of temple, if you will. And you were allowed to just sort of come and figure it out on your own. And so I grabbed my little cushion, grabbed my mat, sat facing a wall for 40 minutes. And that was my introduction to Zazen meditation. And it really stuck for me, in part, I'm sure, because I'm stubborn. I began becoming interested really in resilience first and foremost. And this was back around 2000. And the literature on resilience and the literature on mindfulness was really both, like resilience science were both beginning to evolve and incorporate more objective scientific measures. In my reading, those two fields of thought seem to really be describing the same thing, this kind of presence of mind, this cognitive reappraisal, this kind of command of attention. So not only being able to pay intense attention, but also choosing what to focus our attention on. And then in the early 2000s, the functional neuroimaging data started to come out in both groups. And then it became clear to me they really were talking about the same thing. So I had the thought, what if we used mindfulness to train resilience, if indeed both amplify or enhance or strengthen the same kind of neural substrates and demonstrate the same kind of behavioral outcomes? That seemed like a good shot. Then, of course, I entered medical school and became totally absorbed in that. Still had my own personal mindfulness practice. And then at the end of medical school, looked around at some people I had been very close to going through school and realized how much cynicism I was seeing evolve already, even before any of us went into residency. And since I had known these people from the start, I knew that they were as wide-eyed and big-hearted as anyone when they came in, idealists, really, like so many of us are when we enter medical school. And I wondered if part of the reason I was protected from that was because I had this personal meditation practice. And so then fast forward, I'm ending my general surgery training. I'm at UCSF. I'm talking to Dr. Asher, Nancy Asher, who was the chair at that time. And she was offering me a faculty position and asked what my academic focus would be. And so I told her the truth, that I wanted to study resilience training through mindfulness meditation. And she said, well, we have some of the most stressed out people in the world here, and the effect of them being stressed out or having compromised performance is profound. So why don't you study us? And that was how it started.
That's an incredible story for so many levels. I think, first the balance and the comparison of resilience and mindfulness obviously resonates with me, and I think that makes tremendous sense. And we can get into kind of some of the specifics of that. But I also think there's a really important lesson here for young people starting their careers. You told the truth, and you told something that you were really passionate and interested in. And I think a lot of times people, when they start their careers, when they're starting off, they might tell the chairperson what they want to hear or what they think they want to hear, or try to fit into something that is not necessarily who they are. And I actually think that's a component of mindfulness too, is understanding exactly who you are and what you want to do. So, before we get into the mindfulness-based training for surgeons, if you wouldn't mind, expand for us a little bit there, kind of how you, how you think about that process of, being true to yourself and faculty development and building out a career, whether it's in academics or wherever it may be.
Yeah. Wow. That's so complex, especially in surgery. I really grapple with this right now as my research has expanded to include well-being, surgeon well-being, and expanding beyond individual interventions to systems and culture that need to be changed or modified or rejected. And there's a really important interplay between us shaping ourselves to belong and being rewarded with belonging in surgery, and our need to maintain or develop some sense of self and then be true to that. And I think that's a very fluid boundary. I think we all know a young person coming into surgical training who thinks they already know it all is one of the most dangerous people in the hospital. And so that kind of backseating of one's own thoughts and opinions is really important. I think we aren't all necessarily born able to, like, our reflex isn't necessarily to sacrifice our very selves for strangers. And so that also has to be kind of learned and modeled and practiced. We all want to be that person, but it's different to want to be that person and get up for the 15th time in the middle of the night to go see someone because their Foley's not working. It's so that's a process that requires, I think, setting oneself aside. And at the same time, I think one of the things that's so valuable about a meditation practice is that it maintains and strengthens that core of oneself that is both at peace with who you are and begins to understand more who you are. And so then, even if that is set aside during periods when that's necessary, it's easier to come back to. And so I think going through medical school, I was older, so perhaps that was part of it, but I can't help but think it's also that I felt a very strong sense of self, that I trusted Dr. Asher. I knew that she was a really creative thinker, as well as being such a deeply rooted surgeon. So that was part of my decision to tell the truth. But it was also that, in a sense, I knew my ideas were right, regardless of how they were received, and that I would find a way, even if she had, laughed in my face. And so that was a little bit of luck and a little bit of, I guess, I can't think of the word. It's not really perseverance, more like
maybe providence.
Yeah.
And a wise chair.
Yes. And then when I laugh sometimes because she called in the chief of general surgery, who then became my boss for quite some time, and said, you know, Carter's going to need a faculty mentor here. Why don't you do it? And I didn't know at the time that he actually had a very strong historical interest in complementary medicine. But anyways, it was sort of funny. And he also helped me a ton, actually. I think it's really difficult when you're a young surgeon and you're passionate about something that isn't just strictly clinical, that it's hard to prioritize it. And he really told me, you know, these first few years that you have protected time for research, you have to use it to its fullest extent, because the minute you open the clinical door widely, it's going to be a deluge of work. And he was right. At this point in my career, I'm 100% clinical, and there's no way that I would be able to run a randomized controlled trial.
Yeah.
I'm grateful I did it early.
Yeah, well, beautiful segue. We're going to get into the randomized controlled trial and some of the data. But when you start talking to surgeons about this, how do you approach surgeons about mindfulness? Because I always find this is tricky, because there's a fraction, and it's probably more than a fraction, of surgeons who immediately just dismiss it offhand. And there's a fair amount of people who are really interested in this. So how do you approach it to kind of a wide audience?
Yeah, I thought about this a lot in the beginning, and I talked about it with some people who I thought were unlikely converts and asked them what won you over. And for me, it was a lived experience married to evidence. And so while I couldn't, at least as of yet, back in the past, provide a lived experience to people, I could provide them with evidence. And so I approached this in the most rigorous way I could. And my conversations about this over, you know, years and years now of grand rounds and visiting professorships, and then just individual conversations, has always focused on the evidence. Because I think that one of the beautiful things about us as surgeons and physicians is that even when the evidence asks us to change our thinking, we respect science. And so we will, you know, judge it and scrutinize it. And if it holds water, we will begin to figure out how to change to accommodate something. So that's true of like safety checklists. You know, those were so insulting when they were first brought to the OR, and people were outraged. You know, of course I already do this, and so on and so forth. And Atul Gawande has really interesting publications that I don't know if he intended them to chart his implementation science process, but they really do. And each step of the way of moving this into culture. And I didn't stumble on his work until several years into this, but that was very much the approach I took. And so I bring up the evidence and I talk about it. More recently, I've also started talking about how this fits into mindfulness training for individual surgeons, fits into the bigger picture of systems change and culture change.
So before we get into your trials, what's some of your favorite data to share? What gets the eyes open? What gets people, you know, receptive?
Yeah, I think a lot of it has to do with the military. So I'm often surprised how few people know that in 2008, the chief of staff of the Army made a declaration that his soldiers were coming back from the Middle East conflict, psychologically ravaged. And he went out on a limb to say, we prepare these people with technical skills and battle strategy and, you know, the best possible preparation and training we can give them in every physical and intellectual way. And they are emotionally naked. And this was very much in response to this horrific uptrend in PTSD that they were seeing in soldiers coming back from the Middle East war. And so they went to Penn. They worked with folks there, and a woman neurologist, actually, who's in the military. What's her last name? Cornum, I think. And they developed what later became comprehensive soldier fitness. And it's a mind-body, in part mindfulness-based intervention that began with individuals, teaching, training around how to recognize activation in your body, how to understand your thoughts and emotions, and how those amplify your reflexes, and to really call this out into the open and train people to work on it. And then over years now, they've come to include military members' families, often their children, the top brass within the organization, showing again and again multiple benefits. The ones that they publish are mostly psychosocial benefits and interpersonal benefits, but there are some researchers in San Diego. There was a great paper put out maybe 3 years ago with the first author's name, Johnson, who looked at really complex measures of performance, also post-mindfulness training, and showed definitive benefits there as well. So I think the military evidence speaks to people about legitimacy, right? Because so much of what bothers people about mindfulness is the idea that it's some half-naked hippies in the woods practicing it. So I like those two bodies of data, and I like coming back to them just because I think they're sort of ironclad.
Yeah, I agree with you. I think there's people really do buy into the military examples, and there's the field manual, which is widely accessible. Anybody can access it. I forget which field manual it is, but if you type in Army field manual and mindfulness, you can find it on Google pretty quickly. I always find it interesting that they talk about mindfulness-based training as a way to make soldiers more lethal.
Yes.
But it's true, and the idea is that you are resilient, that you can deal with strenuous situations, and be, for a soldier, a frontline soldier particularly, it is to be more effective. And sometimes that does mean lethality, but it means protecting yourself, the people around you, the mission. And I think there is some wisdom there for why they're doing that, although I don't love the lethality metaphor, but it's the truth. And I think it is so applicable to what we do.
I really do too. But I think you raise a really good point, which is that making sure we continue to promote both the cognitive benefits that mindfulness can bring, which really stem from attentional focus and emotional regulation. Some people add as a separate third skill, cognitive reappraisal or metacognition, completely divorcing those from the philosophical and pro-social elements of mindfulness, I think, is a travesty. What's interesting is that as I was developing the curriculum for surgical residents, there was a lot of controversy about the changes I made to the language. And I had tons of discussions with experts in MBIs and people in research around complementary and integrative medicine, did a lot of reading. And the concern was that there wasn't enough language to specifically promote things like prosociality or peacefulness. And after talking with some monks in Japan and some monks in Mongolia, and then just kind of making a leap, I decided that it was okay, that I thought it would still be beneficial. And so part of the data that came from the first randomized controlled trial, the feasibility elements, was fascinating because it showed through qualitative data that people were talking readily about transformations to their interactions with others, their sense of peace and patience around dealing with conflicts in the hospital, having it help them be more compassionate towards their patients because they didn't feel such raw empathy. And so that really cemented for me that those two things aren't, they don't necessarily have to be talked about explicitly, like skills and this philosophical approach. But I do think we have to be vigilant to make sure that they're not entirely divorced, as in the case of how to be a more lethal killer mindfully.
You and I have never had this conversation in this way before, but that's actually exactly how I present your data. I kind of show the objective because people want to see the objective. And then I love the more subjective, the people's, particularly the participants' responses and how it improved who they were as human beings, in addition to all the objective data we have.
Yeah.
So I think that's an incredibly important and powerful part of this work. And I think pointing that out to people to help them understand that, yeah, there's objective data here. There's black and white. We're surgeons. We have to understand the data, but there's more than black and white here. And if we can change the way we interact on a daily and weekly basis and just feel better about who we are and how we interact with patients and the people around us, we're making a huge improvement.
Well, it's interesting because now this has been going on long enough and it's disseminated enough that other sites are doing their own studies on specifically how ESRT, the training that we use, functions in their environment. And so there's a wonderful study that's been submitted, I think just accepted, looking at 24-month follow-up of Welsh surgical trainees who received ESRT as interns. And the Welsh system, the UK system of training residents is really fascinating because they collect this unbelievably comprehensive data. So it isn't just your ABSITE scores or your third-person standardized reviews, but it's everything, how you match in your next step of wherever you're going, what your outcomes are like over time once you go into practice. So longitudinal things that we don't really have a mechanism for. And so in this 2-year window, what they found was that without further boosters, those who had engaged in ESRT had less stress, less burnout. And then fascinatingly, they had this 13-fold increased odds of matching in the top section of fellowships. So they call it their national training number, but so they were ranked in the highest percentile for their national training number. So really interesting, right? What is that about? I have a new collaboration where we're looking at the role of mindfulness in giving and receiving feedback with kind of an eye towards trying to understand what is the mechanism behind this seemingly like more elevated trajectory that these residents have. Another study that's not published yet that I just saw an abstract for talks about a big national qualitative study that's recently analyzed, and that at institutions where a mindfulness-based curriculum like ESRT or like Taylor Ryle's, I think it's called Energy Leadership, something like that. Yeah, but it's wonderful. And at institutions that have implemented these things purposefully, there's a profound difference in the widespread growth mindset culture, a much greater emphasis on emotional intelligence capabilities, so on and so on. Things that, I guess my point is, are affecting culture. So I'm hoping we'll see more of that, as things go forward.
Yeah, and if you think about mindfulness at its core, right, in setting intention and being purposeful about what you're doing, and just by having these programs sets the intention that this is important and who we are as human beings, not just the technical, is hugely important as physicians and surgeons.
I agree. In fact, now when we offer the course to our interns, and currently I think there's maybe only 1 or 2 places that are offering ESRT and making it mandatory. And that's a whole nother controversy. Many sites make well-being interventions mandatory so they can protect the time. Other sites do it because program directors, experienced surgeons know things about the skill set you'll need in the future that residents in the present can't possibly imagine. And then the other thing, some places say they're keeping it elective simply because residents are adult learners and they don't like to be told they have to do something. Of course, as an aside, no one gets asked if they want to take anatomy or go to skills lab, right? So hopefully as the data and the experience progresses and we come to see that training one's mind is as important as learning how to tie knots and throw suture, the argument about this needing to be a personal preference will evaporate. But in any event, today, when we have these elective, these volunteer groups, I often started out by saying, bring your skepticism. If this doesn't work for you, if you don't buy this, if you don't see benefits, don't ever do it again. It's fine. It's 5 hours of your life. But B, just recognizing that not everyone will use this or benefit from it in the same way. And so while one person might see it directly benefit their surgical practice, another person might see it benefiting their personal relationships or just even their mental health.
Yeah, I think everybody's going to take apart something different from these approaches, and that's okay. That's part of this process, is that it's okay, but you're going to benefit if you participate, if you give into it. I guess give into is the wrong word to say that, but you know what I mean.
If you drink the Kool-Aid.
That's right. No, but I think, I would like to see, I agree with you. Adult learners are challenging. And, the way I kind of rationalize this now is we all should be doing things to work on our physical well-being. I think that literature is growing as well as our psychological, emotional, spiritual well-being. And I think it's hard to mandate that it has to be mindfulness-based training or it has to be cardio on a treadmill. But I think we will eventually get to the point where we can say, listen, your physical and mental, emotional, psychological well-being are important. You have to dedicate certain amounts of time, or let's give you skill sets to allow you to choose which ones are going to work for you. And whether it's running and yoga or basketball and weightlifting, versus mindfulness, meditation, or however approach you want to do it. But I think recognizing that these things are important parts of who we are and how we develop is key.
Yeah, I think you're right. I mean, I think especially for a specialty like surgery where there's a lot asked of us physically, it is very important that we also learn how to maintain our strength, build our strength, build our even just like skeletal health. I do think, though, that one unique thing about mindfulness is that it focuses on the central universal stress response. And so it's not a communication skill. It's not a positive reframing affirmation. It's not remembering to tell yourself you're not an imposter. It goes much deeper than that. And it's that universal stress response that drives our reflexes even before our intellect can engage and say, oh, there I am again, getting angry at the nurse even before I call her back or him back. So it's at a truly, physiologic level. So I think that is one difference. And the other difference I think about mindfulness is that, we can't bring the weights or the, path through the woods or the bottle of wine into the OR with us, right? But the only thing that we bring everywhere is our brain, hopefully. So while I agree, I don't think it needs to be ESRT. In fact, my hope is that as we get over these hurdles of coming to accept just how deeply valuable cognitive training is, someone will come up with something even better. And that perhaps we'll come up with something that runs the course of people's training and career. So it's something that's, iterative over time. But for the moment, I think just building that evidence base to help people recognize that feeling good is not the same as well-being. They're different. One is very personal feeling good is personal. It's also transient, and it's usually situational. Like I feel great when I'm running in the woods, but that doesn't necessarily help me when I'm on my 5th day of 24-hour call. Whereas well-being is about things that are malleable. It's about skills. It also speaks to, like, if you look at the CDC definition of well-being, which I think is a great one, it talks about the quality of relationships, the availability of resources, chance for opportunity and growth. And so it implies the shared responsibility of not just the individual, but the systems around them and the culture they live in.
Yeah, I think really important lessons, right? You can be well and be having a crappy day and feel bad, right?
Yep.
So wellness is so much more than just, feeling good.
Yeah.
So take us, if you don't mind, let's go through ESRT, explain it to us, kind of the basics for the listeners, and maybe in the context of, the foundations of mindfulness in your mind.
Okay. Well, so ESRT is based on MBSR, mindfulness-based stress reduction. That was John Kabat-Zinn's kind of revolutionary secularization of, I guess, really Buddhist practice. And it was marvelous that he did this, because it has allowed people not only to study mindfulness in a scientific way, but also has really opened up the possibility of people who can benefit from the skills that are taught, but might be hindered by the idea of an attached spiritual belief system, to experience these skills sort of freely. And MBSR is gorgeous. I've taken it myself maybe 5 or 6 times. And the reason I did was to look at how is it taught differently? How is it approached? What things are always the same? What things change? What can be left up to the individual, and what really must be adhered to? And in so doing, and as I progressed through my own residency training, I realized that one of the greatest hurdles between this culture, our culture, and our context, and a tool like this is it's cumbersome time-wise. It is meandering in terms of the experience. It's not direct. It's very inquiry-based and sort of naturally evolving. And then much of the language that's used makes people like us uncomfortable. And not that surgical personality or culture is a monolith, but I do think that people who tend to naturally step back from vulnerability tend to be drawn to surgery. And that's in many instances a necessity, right? Like it's not the place to be vulnerable when there's uncontrolled blood spurting in the OR, or you're watching a patient spiral and crash. Or you're dealing with a catastrophe in the trauma bay. That is not the time to be vulnerable. In fact, it's essential that you not be. There's also elements of surgical culture that very much so have made vulnerability a danger. In many, in the past, and still in many places today, being vulnerable as a surgeon can bring your professional ability under question. It can also just leave you open to what can be pretty vicious criticism. So, in other words, there were these cultural and contextual things that were just keeping us from being able to access something like MBSR, which is 8 weeks long. You spend 2.5 hours each week, and then the prescription was for 40 minutes of meditation daily. I mean, my gosh, if you can do that, God bless you. But I've yet to meet the surgeon who can. And therefore, I thought, well, these are the 3 things that I need to tackle. So I need to strip this down to a length that will fit into the constraints of surgical training. I need to simplify it in such a way that it feels like people are learning a skill, not on a spiritual adventure. And I need to find language that I could use describing these concepts and skills to someone in line at the grocery store, and they would understand it. And so those are the 3 things that are different about ESRT and MBSR. It's been a totally human-centered design, iterative process. And so every single time for the first maybe 5 years that I used ESRT, I collected satisfaction surveys, feedback, focus groups, followed up with individual interviews. I observed and took field notes of every single class that we offered in order to understand what lands, what doesn't, what looks confusing to people, what do they immediately understand, what exercises do they prefer. So now it's 5 weekly 60-minute sessions, and we ask people to try and meditate with a goal of like 10 to 15 minutes a day. We know from data that the real payoff, some studies have said 12 minutes, some have said 20 minutes. But we also know that just a small amount of regular meditation can have profound effects. You can have neurocognitive changes. So we don't try to make it too onerous. And then the content of these sessions is really very basic. The first session is just skills. Here are things that you can do anywhere, anyplace, anytime that can help ground you in the moment, that can help bring you back to exactly where you are now. So if you know anything about mindfulness, it's things like feeling the sensation of your feet hitting the pavement, or focusing on your breath, or just noticing something new in your environment. So like Ron Epstein says, look for something red. The second class is about beginning to recognize the constant chatter we have going on in our minds, which are these random thoughts, and that we've really been trained, culturally, to believe that the things that this marvelous brain generates are almost holy. So it's very uncomfortable for us to consider that our brain might just be another sense organ in a way. And just like you don't give your attention to everything in your field of vision, you don't turn to explore every single sound that you hear, you also don't need to give credence and weight and follow to its conclusion every thought that you have. Because actually, many of our thoughts are kind of junk, which maybe Twitter is demonstrating to us scientifically right now. And that's uncomfortable. People don't like that idea. But I would argue, scientifically, that idea seems to hold truth. So in any event, we introduce this concept, and then we begin to show in the subsequent classes how using awareness of one's body can allow us to begin to see this thought waterfall from a different perspective, and then begin to interact with it differently. And then from there, we take people to show how doing so, learning to interact differently with our thoughts and our reactions, gives us a space between experience and action, and it can be transformative. And the final class is about how to use that skill or those skills in interactions with other people, not just for one's own benefit. That's about it.
I love it. It really is. I just jotted down so many poignant things that you've said that are basics of mindfulness, but some of the hardest practically to work out. And I love the idea, or I love the analogy that we don't pay attention to everything in our visual field or in our sound, but we almost always pay attention to our thoughts. And yeah. I know mindfulness-based practice has definitely helped me, especially as you think about being a mindful leader. When you're in a room and trying to come up with a consensus or a direction forward, you can't listen to everybody in the room. You let them speak, but you ultimately have to make a decision in one direction. And I kind of view it that way now, is you have all of these thoughts in your mind. You can't follow all of them. So think about them, process them, weed out the noise and, make a sound decision, because your mind is sometimes telling you all the possibilities, not just the one you need to follow.
Yeah, good point. I think too, a nice thing about cultivating this mind-body skill is that sometimes, at least for me, I might have a thought that sounds like the best thought in the world and one that I should just hurtle down the hallway with. And then I realize that there's a sensation in my body that is not one of thoughtfulness or lightheartedness or kindness or wisdom. It's a sensation of like maybe anger or frustration or fear. And because of that, I have to look again at that thought and ask myself, maybe that thought is just really attractive, but not something that I want to delve into. And I think over time, those are some of the skills that people develop until they become practically reflexive.
Yeah, I'll give one analogy along those lines. I had a colleague recently reach out to me and ask me to, undergo an endeavor with them. I'll just say, it doesn't have to be specific. And my first reaction was, man, this is awesome. I really want to support this person. This sounds like something I'm interested in. And then I noticed two things were happening. First is I was procrastinating to all of the responses to actually, commit to anything. And then the second was, which is the more mindful part, I started noticing kind of the same thing you described, a visceral response to this. So what do? You back off and say, you know what, this isn't right for me. I'm sorry. I was enthusiastic for X, Y, and Z, but you know what, I don't think this is the right time for me now. And that's one of, I think the hardest things to learn as a surgeon and developing surgeon is when to say no. But this is another avenue to learn how to understand your own body's cues of when it's time to say no.
Yeah. Yeah, I think that's really true. In one of the sessions, for instance, yoga is used a lot in mindfulness. And that, many yoga classes, like competitive yoga, which I'm saying ironically, there might be a session at the end where you breathe and say a mantra or something for a few minutes. And I think that's great. But I also think that there's a way to approach yoga that looks at the feeling of release. So not just getting to the pose or holding the pose or doing the pose correctly or better than someone else, but actually, what does it feel like when you let go of that? And that really, that feeling can be amazing. It's like when you stop holding your breath, it feels amazing. And so the kind of corollary to what you're saying about learning to listen to your body, to recognize when maybe thoughts or actions aren't in line with what you really want. What we teach in this course, and something I've found to be true, is that there's also a sensation associated with just letting go of like fixed beliefs or letting go of the need to have it absolutely done your way. Just to come back to earth, I have to say, when I'm in the OR and I have a trainee with me, they are doing it my way. So I definitely have not put down my membership card to being bossy when it's important and necessary. I also should say, because I want people to know that embracing mindfulness doesn't turn us into saints, and it also doesn't make us perfect or take away what is often totally appropriate, anger or disapproval. I just find for myself, and what I see in other people who've adopted this approach, is a different way of dealing with that, and a way that typically is more successful than just exploding.
Yeah, and I think part of the mindfulness based training, you said, the appropriate anger is learning when it's inappropriate too. Because there are people whose teaching methodology, we all went through this, was just to get angrier and angrier until you learned it. And listen, there are some people actually who learn with a little bit of riding and need that motivation, but most people don't. And learning how to be a good teacher, I think mindfulness has helped me be a better teacher too, I would say.
Yeah,
So,
I can do that.
Yeah, I could talk to you for hours, and maybe we'll come back and do another episode, but I want to get into the trials. Tell us and tell the audience, tell us about your trials. Tell us about, the research and what you learned and kind of the process of going through all of that.
Well, the process, what I learned as a scientist is bring your humility, because you'll definitely make a lot of mistakes. or maybe you won't, and then, bless you. But I did. And I'm also so grateful I had a tremendous amount of time to do it. And I'm grateful that I went big. So for both of the single institution randomized trials I conducted, the first one was a pilot, and then the second one was still relatively small and single site, but with about double the population size, the participant size. I did multi-tiered assessments. And so I collected qualitative data. I collected blood samples. I actually, in the first, I think in both of those trials, I also collected urine and hair to look at the hair follicle cortisol levels. I did functional neuroimaging. I did tests of executive function, like a battery that the NIH has created in collaboration with one of our neuroscientists at UCSF. And then I did laparoscopic skills. And that was incredibly burdensome. In fact, I remember it was my birthday, and these are interns, right? So I can't ask them to come by the clinic and drop off their urine specimens. And to measure catecholamines from urine, you need like a bucket of urine. It's ridiculous. I didn't think this part fully through. But I was, I had bought in, so I was going to see it through. And so on my birthday, I was going around to each hospital site where these participants were working to collect the jug of urine that they had collected themselves overnight. And I remember I had like 4, maybe, they're big jugs. I had like 4 of these things, and someone hadn't put the lid on correctly. And so I'm like, it is my birthday. I'm carrying around urine, and I just dumped someone's pee down my leg. This is not glamorous at all. So it was not glamorous. Exactly. I need an assistant. But anyways, I'm glad I did that, because some of those measures weren't sensitive, or perhaps weren't appropriate for this population. It's tricky to study surgeons and to study stress in surgeons because we're always under stress. We have kind of a different relationship to stress. As you said, like the inverted U-shaped curve that you were kind of alluding to, there's an amount of stress on the upward side of that curve that stimulates us and really prompts mastery and often consolidation of learning. But the peak before the fall, which is toxic stress, can often be very sharp, can often happen very quickly. So we're also incredibly intelligent and capable people. So there can be a ceiling effect of several different types of tests that has to be accounted for as well. So I tried this whole spectrum of things, and those measures, tools, scales that ended up capturing something of value were the functional neuroimaging studies, the self-report measures of burnout and mindfulness and stress, the executive function battery, looking at kind of global executive function, the laparoscopic skills maybe a little bit, but it was, I don't know. I'm not sure I put much weight into that study even being large enough to capture, skill changes in skills. And then the whole blood samples that I had analyzed for biomarkers of stress. The hair cortisol in the urine, just the samples were too complicated and didn't work out. So anyways, what both studies have shown is that exposure to ESRT versus an active control, which I think was a really important thing to also have. So block randomized residents, blocked for gender and subspecialty designation, both being exposed to the same amount of time with a dedicated instructor, all together in a community, given breakfast, freed from their service obligations, in order to learn something that has to do with managing stress. And the only real difference was that what the control people were taught was intellectual ideas to think about in order to navigate stress, and the intervention people were taught mindfulness-based skills. And so what we saw was that there was less burnout over time. These guys were followed at least 6 months. In the first trial, 12 months, and in the second, it was 6 months. There was less emotional exhaustion, less depersonalization. There were cognitive gains at the 1 year mark. There was greater mindfulness, both post-exposure and at the 1 year mark. And then the pro-inflammatory markers from this biometric analysis of circulating stress markers in the whole group were shown to go down. And then something that we just finished analyzing, which I'm writing up, so maybe it's dumb for me to say this, but I'm going to say it because I'm so excited about it. What we found is that this functional connectivity between two parts of the brain, one of which is widely recognized as the executive control center and has actually been implicated in numerous studies in surgery with expertise, the development or the possession of surgical expertise. And it's called the dorsolateral prefrontal cortex. And a second part of the brain, which is harder to study because it's right in the middle of the walnut, called the precuneus or posterior cingulate cortex. And those two parts of the brain have this significant enhanced connectivity and activity in the group that received ESRT. And we just saw that within individuals in the ESRT group, that increased connectivity is directly related to decreased beta adrenergic signaling. So that's your fight or flight sympathetic nervous system cascade. And that is also directly associated with reduced perceived stress. So I think that's great. I think it just says it right there.
Yeah, it's pretty incredible work. I love reading the papers, and I'll put the references in the notes for people to access them. But the larger trial is in JAMA Network Open 2019. Just for anybody listening who wants to get to it quickly. But once again, I'll put the link directly in the notes section of this podcast. And I think it's that's just a couple follow-up questions, and I know I want to be respectful of your time today, but do you know how many of these surgeons or surgical trainees continued with independent mindfulness practices after the trial?
I don't know to date, although as part of this feedback study, we're now currently at UCSF 7 years out from the very first wave. And so those are graduating chiefs. And so this is the first year ever where every single class of surgery, general surgery residents at UCSF have had the option to be exposed to ESRT. And so we're writing the protocol right now to pull all of their standardized third-person evaluations to try and see, looking at this natural unexposed cohort and then those who took the training, if there's differences that we can discern. So within that, we will ask people, are you still practicing these skills? The only information we do have comes from interviewing the first wave 3 years after they took ESRT. And this was done in order to develop some videos to show incoming classes so that they might sign up for the study, kind of propaganda. And so really all we were asking was like, please just tell these juniors that it didn't suck. That it wasn't a complete waste of time. But instead, these people sat down and said, I still use this. Some of them actually meditate. Some of them have adapted that to informal practices that they use, for instance, scrubbing in, which a lot of us do naturally, but maybe not as often as we could, or maybe not as purposefully as we could. Some of them actually still sit and meditate. But many of them talked about just calling on that calming reaction, that calming space to interact with people in the hospital or to deal with difficult consults. And then quite a few talked about using those transition skills, those calming skills, to leave work at work and be able to go home and really participate in their home life. So that's the only data we have, but we'll see. They've gotten nothing except that one course, in this case, 3 years before. No boosters. At that time, we didn't even really talk about it after they left the course.
Well, Couple of personalish questions, but I just want to kind of highlight, I think you should be credited immensely with kind of bringing this forward in our field and in surgery. And I hope, we're starting to see this in society in general. And just to kind of timestamp this for people, we're talking to each other in March, and the March Madness tournament is going on. And I saw one of the teams the other day, it was Marquette actually. They were in a stressful situation in the fourth quarter, and their coach sat down and did a breathing exercise for the first 15 seconds of the huddle. And it's something he's employed all season long, very rarely during games. They made that clear, but they did it at the beginning of practices, and they did it, in some stressful situations. But in the fourth quarter, in a really tough situation, sat the team down, and for 15 seconds, they breathed together, and then they addressed the issue at hand. So I think we're starting to see this more broadly be understood, for the benefits for performance in a variety of fields.
Oh my gosh, yes. I mean, I didn't even mention, Tom Brady, Kobe Bryant, LeBron James, Kobe Bryant, rest in peace, but all devoted meditators who very much would say, Tom Brady has a great quote, like, the undisciplined mind follows its own chatter in the echo chamber to the worst conclusion, but the disciplined mind has vision.
Yeah, and I always said it, and part of my impetus was in starting my own mindfulness-based practice. If you look at those elite athletes, those guys are all in the 99.9th percentile of athletic ability. But what separates them, those really elite athletes, is how they can control their mind and emotions, right? Yeah. And so, I think we should be looking for the same examples as, listen, surgeons are elite performers. We're relied to do on some pretty impressive physical things on a daily basis, and having our mind in shape really helps the longevity of a career, resilience, all of the things you talked about.
Yep, I agree.
So I want to ask you two quick questions, and then we'll wrap up. So what's your personal mindfulness-based practice now? What's your mindfulness practice?
Well, now that I'm 100% clinical and trying to do research, I'm right where everybody else is. I feel like I don't have enough time to breathe some days, like literally. So I aim for 5 minutes in the morning, and I try to just do it wherever I find myself. So today I did it when I got in my car in order to drive over here. And I just said, I'm going to leave 5 extra minutes. Sometimes I can actually do it more thoughtfully, and even for a longer period of time, like sitting in my living room or whatever. There are stretches when I'm on call and it's a madhouse where I take my mindfulness in small bites. So every hallway I walk down, I will not look at my phone. I will stop talking, and I will just feel my feet against the floor. Every time I scrub in during those crazy weeks, I don't talk. I just, feel the water, listen to my breath, try to clear my mind of everything that came before that moment. And that informal kind of practice, I think, actually is what is sustained the longest for most people in really time compressed professions. And it kind of allows it to live a little bit more organically in people's lives. We're actually trying now to figure out how to capture that in the next trial that we do, because my sense is that that's actually a really important source of mindful effects, if you will, beyond just formal practice, which is what really everyone has been studying to date.
Yeah, I always found that fascinating. If you look at the tradition of monks and, Buddhist monks in particular, yes, there's dedicated meditation time, but then there's also task-based time, whether it's in the garden or cleaning the kitchen. And they always talk about working on presence and mindfulness in those situations as well. It's a different skill set, but
Yes.
it's equally as valuable. The second question I wanted to ask you is, we talked about vulnerability a little bit and how surgeons kind of shy away from vulnerability, or not so shyly, formally got away from vulnerability. One of the unofficial themes of this season and this podcast has been vulnerability. So if you don't want to tell us, when is it okay to be vulnerable as a surgeon, and how do you demonstrate that vulnerability? Because I think it is an important part of being a leader and part of working in a group, but it is a challenge for us.
Yeah. Well, I think there's 2 places where I've seen it to be most powerful and had it feel most powerful myself. And one is dealing with really painful patients and or complications. That's something that we know over time, if it isn't brought out into the light, like the feelings, the guilt, the sadness, the remorse we have over patients maybe we've cared for a long time and then who die, or who are very young, or we know their families. I mean, scenarios that crop up weekly for most of us. That does register. Those feelings do register. We may not notice them, but they are in us and take up space and compile over time. So I think having vulnerability around that, whether it's, if a person has a therapist or a very good friend or a professional colleague that they can just share with, I wish I had done this differently, or I did everything I could and I still feel horrible, just to clean out the pipes, I think that's one important place, but I also don't think that's vulnerability that should be shared necessarily publicly. Although I do think that there are institutions who are beginning to do that, to have kind of impeccable, unquestionably excellent surgeons publicly talk about some of their complications in order to show people that it's expected, right? Like everyone says, if you don't have complications, you're just not operating. But then I think something that can be done more publicly is a version of vulnerability, which is equally powerful, maybe more powerful on a cultural level, which is intellectual humility. And that's really having an approach similarly to how we talk about approaching emotions or events from a mindful perspective, which is non-reactively and without judgment and without assumptions. And how that plays out in intellectual humility is, if I'm operating with a resident, or I'm in a conference with another faculty member, or I'm at a conference and there's a topic being discussed, I try to make room for others to say what it is they have to say before I decide anything. It allows me to hear them and to consider that maybe I don't know the whole picture, or maybe what I understand to be true isn't true. That's certainly been a mantra throughout all this research. Like, is it true, or do I just think it's true? And I think that place of humility ends up being really powerful, because it allows us to learn the truth, about our own biases or about some part of reality that we weren't paying attention to. It also invites people to collaborate, whether it's an intraoperative decision-making or learning how to deal with zebra patients or problems, in your institution. And so I think that also is a form of vulnerability, because we're typically trained to be so assertive and certain, often, frequently, to a fault.
Well, thank you so much. We're coming up on that time, so I just want to give you the opportunity, if there's anything you wanted to say to the audience that we missed. But this has been a tremendous conversation, and I jotted down so many notes that I'll summarize in a sec. But just wanted to give you the opportunity and thank you for the time today.
Well, thank you very much for having me. It's really great. Learning about you and the work you're doing and kind of your mission just gives me a lot of hope. So I guess all I would say to people is, one of the maybe most powerful things we can do in terms of well-being or acting in a mindful or thoughtful way is to collaborate with each other. Each of us is incredibly powerful and productive and capable. And if we can set aside the pressure to compete all the time, it's astounding what we can accomplish. So I'd leave it at that.
Well, thank you. Well, I'm just going to say some of the amazing things you said throughout our last hour together. We started the story talking about where mindfulness came from in your origin story, and you told us it came from a kind of a search to find resilience in mindfulness. And you started with the story when you were a brand new surgeon, seeking the truth and being honest with your chairperson at that time, and really having a tuned in sense of self really helped you kind of find this career and this endeavor and all these great things you've done in surgery. And you talked how mindfulness and meditation can strengthen the core of oneself. You talked about the key components: attentional focus, uh, emotional recognition, and then cognitive reappraisal. And having those skills and teaching those skills to other surgeons really improved who they were in a number of trials that you've conducted and participated in over the years, giving us a real source of data for mindfulness in surgery and a foundation from which we can move forward. So can't thank you enough for that. And I think one of the really interesting things, if we can't get everybody to buy into this, you gave us 2 data points where the residents in the Welsh system matched into better fellowships, and now we're having functional brain data showing better expertise with after mindfulness-based training. So even if people don't want to buy into mindfulness, you can become more expert and match it to the fellowship of your choice if you do a little mindfulness-based training. No, but I think it's a tremendous body of literature. It's a tremendous body of work. And thank you so much for sharing your time and expertise with us today.
Yeah, my pleasure. Thanks for having me.
Good. Well, I know so many people are going to benefit from this conversation. Thank you very much, Dr. Lebares. I look forward to working with you in the future.
Oh, yeah, me too.